it's Beth Russell here again with Module 3 of the Run PC Triage Tool training course, which is on actually using the Run PC Triage Tool. Just to recap our key points from Module 1, we learnt that triage prioritises patients based on their urgency of need. Triage in palliative care is complex due to differing goals, needs and types of needs of the patients referred. And we really need transparency and consistency both within and between palliative care services. So a standardised palliative care triage tool is to be applied after referral and determination of the patient's eligibility. It doesn't help us work out if this patient is eligible or appropriate for palliative care. It just helps us work out their priority once we've already established their eligibility. It's not a prognostic tool. It doesn't negate non-clinical factors involved in organising ourselves or the ethical complexities, but it does make decision-making more explicit and reproducible. From Module 2, we learnt that the Run PC Triage Tool is based on a literature review, a qualitative study, an international discrete choice experiment, and finally a validation study. And these have all been published, and you can find the articles on our Palliative Nexus website. The tool domains and scoring system reflect the attitudes and practices of over 700 experienced palliative care clinicians from around the world, and the reliability and validity of the Run PC Triage Tool is comparable to other commonly used assessment tools in palliative care. So today we're going to cover the actual tool item definitions and some user tips. Then we'll work through some examples of real referrals for the inpatient setting, the community setting, and then some frequently asked questions. So firstly, the Run PC Triage Tool item definitions and user tips. So the tool starts with an emergency caveat, and the wording of that is as follows. In the case of a suspected or impending medical emergency, such as a spinal cord compression, SVC obstruction, airway obstruction, seizures or acute bleeding, to name a few, or a psychiatric emergency, such as agitated delirium or suicidality, discuss with a senior clinician immediately, regardless of score. So really, patients who would want investigation and or intervention may need urgent medical attention, and a palliative care admission or consultation isn't always the most appropriate course of action. So even if the patient scores very highly, there still may not be a bed or time for an extra visit or consultation. They need to be highlighted to a senior clinician. And likewise, they might actually score quite low on the tool, and that doesn't matter. They still need, if you have clinical suspicion of these issues, their care needs to be escalated and considered. So item 1 on the tool itself is physical suffering. So that's physical suffering or distress of the patient. That can be any physical symptom experienced by the patient that is causing suffering or distress. So it might include pain, dyspnea, which is shortness of breath, nausea, vomiting, constipation, diarrhea, even itch. And we've included here agitation and confusion as these symptoms, which might be connected to a delirium, really fall into the physical category and need to be treated as such. We use the language suffering or distress really to assist referrers to identify how the symptoms are impacting the patient's experience. So you might the response options for this item are unknown, that you don't have any information about their physical suffering. Nil, that you're confident that, you can make an assessment that they're not experiencing physical suffering. Mild, moderate and severe. So in mild, they might have symptoms that are generally well controlled. They might be using a few PRN doses of a medication for that symptom, and they're finding that relatively effective. And there's not really any changes to management planned, and their symptom severity is relatively stable. Moderate might mean that they are using PRN doses, but finding them only partially effective to control that symptom, and they're really having an inadequate response to management. Or further changes to management are anticipated in the next few days, and their symptoms might be worsening. For severe, it might be that they're using PRN doses of medication frequently, or they're finding that their regular or PRN doses are not effective. And really, further changes to their management are definitely required urgently, and they might be having rapidly worsening symptoms. So those are not really a checklist, but just some suggestions of how you might characterise mild, moderate, and severe for physical suffering. Item 2 is psychological suffering. So that's psychological or spiritual suffering or distress of the patient. So this is any psychological symptom experienced by the patient and that is causing suffering or distress. So it may include anxiety, depression, or existential distress. And again, we're using that language of suffering or distress to assist referrers how to identify how the symptoms are impacting the patient's experience. That was something that came out of our qualitative work. The response options here very similar to physical suffering but scoring lower. So unknown when you don't have any information about their psychological state. Nil when they're not having that psychological or spiritual suffering. Mild, moderate, or severe. So mild might mean that they're having sort of intermittent low mood, anxiety, or distress, or they have a well-treated existing mental health disorder. Moderate might be where there are some complex factors like dependence in their life, like children, finance issues or housing issues, and psychological services might already be involved, such as psychiatry, psychology, social worker, family support worker, and they're needing some holistic care from specialist palliative care to bring things together. And severe might be where there is risk of harm to self or others, and in that case need to consider using that emergency caveat that I've already gone through. And they really are needing holistic care from a specialist palliative care service daily. And these psychological symptoms may well be exacerbating their physical symptoms, such as with the concept of total pain or compliance issues. So again, just some ideas and descriptors for how you might allocate or assess mild, moderate versus severe. Item 3 is caregiver distress. So this is distress or burnout of the caregiver. It might include anxiety, depression, exhaustion, or existential distress. And it can apply to the lay caregiver, husband, wife, daughter, brother, at home, even when the patient is in a hospital or residential care facility. Or it might also apply, albeit less commonly, to the health professionals involved, perhaps feeling a bit overwhelmed by this person's care needs. The response options, again, an unknown option, nil, mild, moderate, or severe. So really how you might determine mild, moderate, severe might be very similar to the previous item of the patient's psychological distress. But in addition, really we would say for mild, there would really be very, very minimal or no impact really on their ability to support the patient. For moderate, there would be a minimal impact on their ability to support the patient. And for severe, there'd be a significant impact on their ability to support the patient and or they'd be expressing severe distress. Item 4 is communication needs. So this is urgent and complex communication or information needs of the patient or the caregiver. So either can flag here, and sometimes they are disparate. They have different needs. One has needs, one doesn't, etc. So either can flag. And just a couple of examples here. So coming out of our qualitative work, mismatched goals of care or understanding of the disease stage might influence management decisions and lead to suffering. So for example, pursuing investigations or aggressive therapies when that's unlikely to impact their prognosis. That might be a situation where you really need some urgent, sophisticated input around talking about their goals of care or their disease stage to help them with that decision making. Also, advanced care planning discussions may be pressing when a patient is deteriorating rapidly and or may soon be unable to comprehend or communicate, for example, in the setting of a progressive neurological disease. So that can become quite pressing. The response options there are unknown, no, and yes. Item 5, discrepancy in care. So significant discrepancy between the patient's care needs and their current care arrangements. So the patient's care needs might include hygiene, washing in bed and toileting, etc., medication administration, including subcutaneous infusions and subcutaneous PRN doses, psychological care and medical management. And their care arrangements include everything from the lay caregiver's abilities, willingness and capacity, professional caregivers' expertise and accessibility, including outside of business hours, who's available to give that patient access to what they might need to control symptoms and deal with problems, the equipment available and in place, and their location. And we've just made a little note here that this is including implications for the lay caregiver's transportation needs. So potentially a situation where a patient might be admitted to a hospital that is a long way from that caregiver, who might be reliant on public transport, etc. So those things would fall into this category. So the response options here are unknown, when there's no information about it, nil, impending and current. And so I just wanted to highlight this item really is a dynamic and contextual concept, as a patient with a good performance status but poor supports may have more urgent needs than a patient with a poor performance status but good supports. So it's really the discrepancy between the two, their performance status and independence and care needs. How does that match up with what's actually in place for them? So use discretion when you're selecting impending versus current. So, inadequate home arrangements when a patient is being discharged from inpatient care tomorrow could be assessed as current by a community service, because it's really an imminent, right now kind of problem if they're going to be sent home tomorrow and those supports are not in place. Versus a request for respite next week could be assessed as impending by an inpatient service. And we'll discuss respite in more detail later in the presentation. Item 6, desired site of care. So this is a mismatch between the current site of care and the patient or caregiver's desired site of care, and really distress of the patient or the caregiver due to that current site of care. So they might have a preference to be somewhere other than where they are, but it's really when they're distressed about that. And this is relevant even if the care is technically adequate in the current location, as facilitating care that enables patients to be cared for in their desired site of care is an important patient-centred outcome. Again, this came out clearly from our qualitative work. So the response options here are unknown, no, and yes. And finally, imminent dying. So the patient is imminently dying. So this is when the patient is expected to die within days and no acute intervention is planned or required. And typical features may include reduced conscious state, loss of swallow, and profound fatigue and weakness. And the response options are unknown, no, and yes. Just some user tips to consider, having gone through the 7 items. This tool, as we've mentioned before, is really to be completed by an experienced palliative care clinician, not the referrer. So referrers might be experienced palliative care clinicians, but they might be junior doctors on a ward somewhere who haven't had any palliative care experience. This might be the first patient they're caring for who's got palliative care needs. It could be people from all different aspects of the health service, with variable amounts of palliative care experience, perhaps speaking a different language to what we're used to. So we feel that, and this again was coming through in the qualitative work, it's really important that someone with palliative care experience is teasing this out, and particularly around things like imminent dying, but really making some assessment of the information that they're given and putting it all together. So they're really drawing out maximal information, but inherently that assessment will be subjective. You're not seeing the patient in general, you're not seeing the patient or caregiver in front of you. You're basing your assessment on secondhand information, maybe from a variety of sources. So it's really making your best, most informed and educated assessment, noting when you don't have information present. And that's number 3 there, when you're ticking the more information required box. And that's really to mark on that triage assessment. I've done my assessment. Maybe I have a couple of unknown boxes ticked where I don't have any information, or I've made an assessment but I would like more information. And in that free text part, which we'll get to the tool online shortly, but in that free text option you can actually make notes there of what information is missing, and perhaps you're planning a phone call the next day to the caregiver, etc. And that just enables you to document what's missing, and so that can be handed over to a colleague perhaps if you're not working the next day, etc. If in doubt, higher scores are actually more conservative. Nobody wants to be the boy that cried wolf, but we need to remember in this setting that we're making assessments about how soon we're going to make contact with this patient and admit them or go and visit them at home without having actually seen them ourselves. So if we're wondering, is this moderate or mild? Is this severe or moderate? If in doubt, go with the more severe option, because that's sort of assuming the worst, and we would rather prioritize that patient and then go and find, actually it's not as urgent as we thought, than miss an urgent situation. And as I've said previously in the training, it is quite hard to score high on the tool. You'll notice that the scores all sort of bunch down the lower range of the spectrum. So have confidence to not be afraid to perhaps overcall things. That's actually the safer option in this setting. Do use the emergency caveat combined with your clinical judgment. So even if it doesn't fall into the emergency caveat criteria or description, if your clinical acumen is telling you, there's something here that is really concerning me about this patient, I want to deal with them more quickly, then by all means escalate and discuss with a senior clinician, or if you are that person, escalate their care and prioritize them, because there are going to be some situations that don't get captured. And finally, it's really important to manage waiting lists actively. So in general, patients with a higher Run PC Triage Tool score should be tended to first, aiming for within the recommended response times for the relevant setting, community or inpatient, unless there are complicating factors. So for example, a patient might require a single room and there are only shared rooms available in your inpatient service, or a patient requires an interpreter for a home visit and they're not available until a certain day. But in general, patients with higher scores should be tended to first. Patients who receive the same triage score should be prioritised in order of the time of referral on a first-come, first-served basis. But the patients who are on the waiting list really should be reassessed regularly to monitor if their situation becomes more or less urgent. The frequency of that reassessment is dependent on their acuity level. So we would suggest that the minimum would be weekly, but for a patient who's considered likely to deteriorate quickly, then daily or alternate daily checking in and just checking is the situation still the same. If not, I'll repeat the triage tool and get a new score, and then they're going to be prioritised in a higher manner. So let's move on now to some worked examples for the inpatient setting. If you could, on another screen or device, go to palliativenexus.org, which is our palliative medicine research group's website, you'll find under our research the Run PC Triage Tool. And on the left there you can see the button to go to the Run PC calculator, on the right to the user manual, or something very similar. This is going to be updated fairly soon. And if you click on the actual tool, this is the sort of thing you'll see, where we've got the emergency caveat at the start there, and then drop down options for the items, and then the score is calculated. You can see the option there at the end for further information needed, and then a free text option to write any notes about perhaps particular concerns you have, or further information that you're chasing up. So if you've got that going next to you, then we'll work through these examples together. And by all means, pause and work through it yourself and see what you come up with, and then continue on with the presentation, and you can see how I approached it. There's no definite right and wrong, and it can be really helpful to do this in your working groups, perhaps with a colleague from your palliative care service, just to see how you're both approaching information and filtering it and applying the tool. And it's really helpful to do that on a regular basis, to sort of calibrate with one another and get that peer review. So this is a real patient. It's been de-identified, but a real referral, and you'll notice that some information's missing, some of it's really, really clear, some of it's perhaps implied, and it's important that we practice on this type of information that's not precise and neat and the boxes are already ticked for us, because this is really our real life, working life. So you receive a call from a palliative care nurse at a nearby community palliative care service referring a new patient to your inpatient palliative care unit. The patient is a 66-year-old woman with glioblastoma who has been increasingly agitated and confused over the last 2 days. She's been severely vision impaired for many months due to her brain tumour, but has recently also developed impaired mobility. She is now unable to coordinate getting in or out of bed and is unable to walk. There is a hospital bed and a commode in the house and clonazepam drops available for her agitation, but her husband feels unable to cope and is requesting an admission. Her 2 adult daughters have been staying over the weekend to assist with her care. She has previously stated that she wishes to die in an inpatient hospice rather than at home. Her husband and daughters are aware that her current presentation could represent a rapid deterioration leading to death. So how do we apply the tool in this setting? So this is how I've done it, open to discussion, of course. So for physical suffering or distress, I've put moderate. Her agitation and confusion really flags on that one, and it sounds as though it's been getting worse and really needs some attention. So I've said at least moderate for that one. Likewise for psychological suffering for her. The caregiver, the husband, is basically saying, I'm unable to cope. So I think that really warrants a severe distress and burnout of the caregiver. To me, it sounded as though there weren't any pressing communication or information needs. It sounded as though the husband and daughters were aware that she's going to deteriorate, and this could be it. This could be the significant beginning of the terminal deterioration. Of course, in real life, you'd be teasing out more information, but I felt that there was enough there to say probably that there weren't pressing communication information needs. There is a current discrepancy between care needs and care arrangements. So yes, he has the bed and the commode and the clonazepam drops, but the situation isn't working. She's agitated, she's not able to do the transfers. What's in place is no longer working. So that's current. And there's a mismatch between site of care and desired site of care. That's been also stated explicitly. I didn't feel that I was able to make a call whether she was imminently dying. It sounded as though she's definitely deteriorating, but whether she's really entered that terminal phase, I mean, she's still awake. I probably needed more information there. So I said unknown, and you can see the total score calculated was 52. So applying that in our recommended response times for referrals to the inpatient unit setting puts her in the crisis category, which really means we're going to aim to get her in within 24 hours. Okay, next example, number 2. This is part 1 of number 2. You receive a call from a palliative care nurse at a nearby community palliative care service referring a new patient to your inpatient palliative care unit. The patient is a 65-year-old woman who lives at home with her husband and 2 adult children, both of whom work full-time. She does not speak any English. She has bowel cancer with progressive liver and lung metastases on recent scans. She is deteriorating with nausea, jaundice, ascites, dyspnea, and bilateral leg edema to her waist. She is incontinent and now too weak to get out of bed. Her husband is struggling with her care needs and hygiene. They do not have any lifting equipment at home, and she is being referred for symptom management and likely end-of-life care. So applying the tool here. So the description we've got there doesn't actually quantify the severity of any of her symptoms other than her bilateral leg edema, which it said was up to her waist, which is severe. But I've definitely put severe there for physical suffering. There were multiple symptoms listed. So it's unclear if it's distressing, but there was a lot of symptoms. We'd certainly need more information about the severity, but I felt that warranted putting severe for item 1. There's really no information about her psychological state, so I put that as an unknown, and that's something I would flag to come back to try to get more information. It sounded as though the caregiver, the husband, was really struggling, so I put at least moderate for that. Be open to putting severe, but I put moderate. Not really any information provided at this stage about their communication or information needs, so I put unknown, but a current discrepancy between care needs and care arrangements. It sounds like it's really not working. They don't have lifting equipment. The things that she needs to be comfortable at home are not in place. We don't know about her desired site of care or her family's desired site of care, so I put unknown for that, and likewise for imminent dying. That gives you a total score of 47. And looking at the inpatient unit setting referrals, that puts her in the category of urgent, aiming for a response within 48 hours. So even with the multiple unknown responses, which score 0, and needing more information, this still falls within the urgent category. And then I provided a part 2 where we've received further information about her. She's actually barely conscious and not taking any food or fluids orally, and her husband does not want her to die at home. So, if we receive that information later in the day or the next day, we could repeat the tool, and as you can see there, I've then ticked that number 6, yes, there's definitely a mismatch between the current and desired site of care, and yes, the patient is imminently dying. So that then gives her a score of 70, crisis, admit within 24 hours. Okay, so inpatient example number 3, part 1. You receive a phone call from a nurse at a nearby community palliative care team referring a new patient to your inpatient palliative care unit. The patient is a 62-year-old woman with metastatic breast cancer who has progressed through multiple lines of chemotherapy and is now for hormonal therapy only. She's quite stable with some chronic pain related to bony metastasis and intermittent nausea, but both are adequately controlled on her current drug regime. Her mood is good. She is frail and fatigued and requires assistance for showering and mobility around the house. She lives with her daughter, who is her full-time carer. The daughter is not distressed but is tired and requesting a period of respite next week for a short holiday away at the seaside. The patient is being referred to your team for a brief inpatient stay to facilitate this respite. So applying the tool, it's fairly clear that her physical suffering is mild. She does have some symptoms, but they're fairly well controlled. There's no psychological suffering that we've been made aware of there. The caregiver is tired but not distressed, so I've said mild there. There didn't really flag any information about communication or information needs, so I've said unknown. And this is really how we might deal with a respite referral, that the discrepancy between the care needs and the care arrangements is impending. So the daughter is going to go away, so there's going to be a discrepancy that the patient can't stay home by themselves without that care, but it's not current, it's next week. Mismatch between current site of care and desired site of care, just remembering that that's around the distress about the site of care, so that's no, and she's not imminently dying. So that gives a score of 6 at the bottom there, putting it into the routine category, admission within 7 days ideally. So you're going to be talking with this family about the timing, what day of the week is it now, when are they planning to go away. And I've just given a part 2 update, so 1 week has passed and no bed has become available for the patient to be admitted. Forced to delay her holiday, the patient's daughter has realised now how exhausted and burnt out she is. She's teary and despairing over the phone when receiving daily waiting list updates. So we can then look at the tool again and upgrade some of these categories. So number 3, the distress or burnout of the caregiver, I've put as moderate. Number 5, the discrepancy between care needs and care arrangements is current. Really, she wants to go away any day. The holiday is overdue. So I've put that as current. It's really imminent. And still a no for the others there. So that gives a score of 15. Moves it, doesn't actually, move it up a category. It's still routine. And, I guess that this is one of the difficulties around respite we'll talk about in the frequently asked questions section, but she would still not score as highly as someone who's really got out of control symptoms and issues. So it's really around the caregiver's distress here, and you'd want to keep on reassessing her and seeing how she's going, but not scoring particularly high. And our fourth and I think final example, you receive a call from a palliative care physician at a nearby community palliative care service referring a new patient to your inpatient palliative care unit. The patient is a 91-year-old man with locally advanced squamous cell carcinoma of the jaw. He is living in a supported residential facility. He has been deteriorating over the last week with decreased oral intake, unsteady gait and fatigue, spending more time resting in bed. His hearing has deteriorated and he has developed a fungating malodorous malignant jaw wound. Recent scans confirmed tumour progression with local invasion. His pain is currently well managed with a fentanyl patch, but he has become withdrawn and despondent and does not want to be alive anymore. He thinks the staff of the care facility are trying to prolong his life so they can financially benefit from his residential fees. He has repeatedly told his daughter that he is living his nightmare and has asked her to help end his life. This has caused significant distress for her and conflict between the two of them. He is not evidently confused. He does not want to die in the residential facility. The residential facility does not have registered nurses available overnight to administer subcutaneous medications for symptom control or in the event of a catastrophic event such as a bleed or airway obstruction. So applying the tool, I've said severe for physical suffering. His pain is well controlled, but he's got this fungating malodorous jaw wound that's increasing. He's got a lot of distress with that. Likewise for psychological distress, he's living his nightmare, wants to end his life. That's a severe. Likewise for his daughter, she's very distressed about all of this situation. Don't have information about the care staff at the residential facility, but I would suspect that they're feeling pretty distressed about the situation as well. So that would flag on number 3 too. Urgent and complex communication or information needs. So there's these concerns from him about the intent of the staff, and there's conflict between him and his daughter. So I would say a yes, that there needs some urgent counsel brought in here to help work through some of these issues. There's a current significant discrepancy between care needs and care arrangements. They don't have access to subcutaneous medications. There's not the staffing overnight. He's deteriorating and becoming less stable. He is unstable. And there's a mismatch between his current side of care and desired side of care. He's very distressed about remaining at the residential care facility. I said no for imminently dying. He's certainly deteriorating and maybe deteriorating rapidly, but it sounded as though he hadn't entered that final phase yet, but could do fairly quickly. So overall, that gives it a very high score of 86. But I would also say that he would meet that emergency caveat. So although his score of 86 puts him in crisis, he's really talking about wanting to end his life. This situation sounds pretty out of control. So really, we'd want to discuss this with a senior clinician immediately, regardless of the score. He might be at the top of our waiting list, but we might need to, if we don't have a bed for him, we might need to do something else for him, given the scenario we're hearing. And one more final example for an inpatient referral. You receive a phone call from a palliative care consultation team nurse at your own hospital, referring a new patient to your inpatient palliative care unit. The patient is a 32-year-old woman with a primary brain tumour. She has progressive disease on recent imaging, but has already had maximal treatment and is now for a comfort-focused supportive care approach. She has been admitted under the oncology team with intractable hiccups, which are thought to be related to her tumour or possible seizure activity. The hiccups are quite forceful and are distressing for her and causing extreme sleep deprivation. She also has had increasing motor weakness on the left side that is impacting her mobility. She has been seen by the palliative care consultation and neurology teams, and various medications are being trialled for her hiccups, with small improvements thus far. She is currently in a 4-bed hospital bay and her hiccups are disturbing the other patients. She is being referred for ongoing symptom management, psychosocial care and discharge planning with appropriate allied health assessments. So applying the tool here is a great example of how a symptom such as hiccups can actually be severely distressing. So I've put severe for physical suffering and a moderate for psychological suffering, given the information we've been provided. We don't really have any information about her lay or professional caregivers, so her family or partner or the care team on the ward currently looking after her. So I've put unknown for that, but we'd certainly want to seek information about that. And around her communication or information needs, we also weren't given any information, but could tease that out, ask some more questions. Discrepancy between care needs and care arrangements, I put impending. You could potentially put current, given the 4-bed bay that she's in and disturbing the other patients, and no doubt disturbing the other patients is sort of compounding her own distress. So you could actually put that as current. And mismatch between current side of care and desired side of care. We weren't given that information, but that would be fairly easy to find out. I put not imminently dying, and so that gives a total score of 44 and puts her in the urgent category for inpatient referrals. But that score could possibly go up with some more information. So I hope those examples have been helpful for inpatient referrals and maybe some crosstalk with community with some issues that appear in both. So let's move on now to some worked examples for the community setting. First one here, a consultation liaison palliative care nurse at a nearby hospital is referring a new patient to your community palliative care team. The patient is a 69-year-old woman with metastatic pancreatic cancer. She is currently an outpatient receiving second-line palliative chemotherapy every few weeks. Her disease is widespread but has been stable over the last 3 months whilst on the current chemotherapy agent. She is generally managing well physically but suffers from severe nausea with each chemotherapy cycle, so the referring nurse would like your team to be available to administer injectable antiemetics to her in her home at those times. She is currently between chemotherapy cycles and feeling good other than mild fatigue. She has had difficulties with anxiety regarding her cancer diagnosis, but is currently managing this well with the help of a psychologist. She is aware of her prognosis and is able to express grief appropriately, but struggles to discuss her cancer with her partner. So applying the tool, really her symptoms are well controlled at the moment between cycles, and the information was quite clear about that. So I've put mild. But obviously, in our discussions, we'd want to be finding out, well, when is that next cycle of chemotherapy due? Because that we can predict that her physical suffering will be high at that time. So for the moment, it's mild. Likewise, she's got mild psychological suffering. She's engaging with a psychologist, so that's mild. We don't know about how her caregiver, her husband, I think it was, is travelling, so that's an unknown. And although it sounds as though she could do with some help in broaching the topic with her husband, it's not really it's not really urgent. So I said a no for that for item 4. This discrepancy between care needs and care arrangements is impending. So when that next cycle of chemotherapy comes, that would that would really be flicking over to current, but at the moment she's going to need that subcutaneous medication administration, but we might have a fair bit of time before the next cycle, and that's the information we need to gather. Mismatch between current site of care and desired site of care, not as far as we know, and not imminently dying. So that gives a score of 6, which is very low, and for referrals to the community setting down the bottom of the table here puts her in the routine category. But as we've said, needing to dig up a little bit more information about what's to come and plan ahead. Example number 2. You receive a phone call from a junior doctor on the palliative care ward at a local hospital, referring a new patient to your community palliative care team. The patient is a 73-year-old woman with metastatic ovarian cancer. She has progressive disease on recent imaging and is not for any further anti-cancer therapies. She was admitted to the inpatient palliative care unit 2 weeks ago with nausea, ascites and gram-negative sepsis, with bacteremia due to spontaneous bacterial peritonitis. She was very unwell at that time and indeed almost died. Her ascites was drained and she was treated with intravenous antibiotics, and she initially improved. She is now comfortable on a syringe driver of antiemetics and is not showing further signs of sepsis or other reversible conditions, but is deteriorating overall. She is not eating or drinking and is sleeping most of the day. Her prognosis is likely only days. She lives alone but has a very supportive network of friends. She is distressed at the thought of dying in hospital and has stated she would much prefer to die in her home. Her friends have rallied with a roster to have 1 to 2 people present at all times to care for her. She is being referred to your team to provide ongoing symptom management and end-of-life care in her home. So her symptoms are under control with the current regime. So I've said nil for physical suffering. Psychological suffering, I've said a moderate, that she's distressed about wanting to get home. That's her issue, and sounds like she's quite distressed about that. The network of caregivers sound like they're all good to go and not distressed and burnt out as far as we know, so I've put a nil and with no urgent or complex communication information needs. The discrepancy between care needs and care arrangements I've put in pending. You could actually put current, given that she really could be discharged from hospital at any point and ASAP. So really from the community team perspective, we could easily put current for that. And yes, for mismatched side of desired and current side of care, she really wants to not be in hospital, wants to be at home, and she's distressed about that. And I said yes for imminent dying. Maybe there's several days, but it sounds as though she's really entering that phase now. So giving the more conservative option is to say yes rather than no. So that gives a score of 35, putting her in a crisis category for the community setting. And you'll notice, as we've pointed out before, that the scores for inpatient and community are different, and a lower score on community often does fall into a higher urgency category because scores overall in the community setting are lower, given the lower acuity. So she's really going to be prioritised, and we'll discuss in the frequently asked questions section about syringe drivers, but she might be someone that your service prioritises just because of the syringe driver requirement. Example number 3. You receive a phone call from a palliative care nurse working at a nearby hospital, referring a new patient to your community palliative care team. The patient is a 66-year-old man with pancreatic cancer that has metastasized to the lung and liver, diagnosed only a few weeks ago. He lives at home with his wife, who is supportive and coping well. He has some left upper quadrant abdominal pain, for which he takes a long-acting opioid. He has a supply of immediate release opioid also, however has not felt the pain is severe enough to need to take it. He also reports loss of appetite, constipation and fatigue, although he continues to be able to enjoy day trips and outings with his friends. He has a past history of depression, but his wife feels he is handling the news of his diagnosis quite well thus far. He has been offered palliative chemotherapy but is ambivalent about this and is currently thinking he will likely opt for best supportive care. He is being referred for introduction to palliative care and ongoing symptom management. So applying the tool, yes, he's got symptoms, but his pain is well controlled. He's hardly taking any medication. He does have constipation and fatigue and one other symptom, but it's not really limiting him getting out and about. So I think that's fairly clear that his physical symptoms are mild. Likewise, we've been given information that he's coping quite well psychologically, and his caregiver is also coping well. There weren't really any urgent and complex communication or information needs flagged. He's making a decision about his treatment options, which is really for discussion with his oncologist, maybe the palliative care team too, but is not really urgent. That's something that's going to tick over with time. There was no significant discrepancy between care needs and care arrangements, nor a mismatch between his desired side of care and his current side of care, and he's clearly not imminently dying. So overall, he actually scores 0, and this is a good example that would fall in the routine category. A good example that scoring 0 doesn't mean that they're not appropriate for specialist palliative care. The decision about whether or not he's appropriate and eligible for specialist palliative care is separate to the triage and assignment of priority and urgency. So in fact, early referrals like this should be encouraged. So, by all means, we need to see this patient. It's just that we're not going to prioritise his care over someone with poorly controlled symptoms or other more pressing issues. Since we have on the tool marked some of his responses as mild, we can sort of prioritise or, by hand select him out over the patients that actually have 0, 0, 0, 0, 0. But, there's not really a right or wrong there. It's of little consequence. He needs to be seen, but not in a hurry. Another example here, you receive a phone call from a local general practitioner referring a new patient to your community palliative care team. The patient is a 52-year-old man with a glioblastoma multiforme for which he has declined the offer of chemotherapy. He had a recent fall and sprained his ankle, was admitted to hospital and then had a period of rehabilitation, but his mobility has continued to deteriorate despite an increased dose of dexamethasone. He is now home but wheelchair bound and only just able to transfer from his wheelchair to bed. He has a stool to use in the shower. He is very fatigued and his cognition is increasingly impaired. He has a history of anxiety and depression. His wife is struggling emotionally and physically and does not feel able to cope with his care needs. He has been referred for psychosocial support and care coordination. So moderate, I've said, for physical suffering with his decreasing mobility. We really could tease out more information, and he needs a good symptom screen because there wasn't that much information provided in that little intro there. But it's a little bit hard to interpret. The cognition is increasingly impaired. Is this confusion? Could it be delirium or a steroid effect, or is it tumour progression? So I think to err on the safe side, I would put at least moderate for his physical suffering. We're not really given any information about his psychological suffering, so I've said unknown, and we need to tease that out. Clearly, his wife feels she's not able to cope, and when someone says not able to cope, I think that's a severe for number 3. No information really provided about their communication or information needs, so I've had to say unknown for that. But there is a current discrepancy between care needs and care arrangements with his mobility and the state of his caregiver. So that's a current. We don't know about his desired or her desired side of care and versus his current side of care. So I've said unknown and that he's not imminently dying. And that gives an overall score of 37, which in the community setting makes it a crisis for an urgent response. And number 5, I think this is the final community example. So a palliative care liaison nurse at a nearby hospital is referring a new patient to your community palliative care team. The patient is a 58-year-old woman with metastatic gastric cancer. She is currently an inpatient with terrible nausea, vomiting, and abdominal pain and ascites. She has a nasojejunal tube in situ, which was originally inserted for feeding, but is now being used for drainage of intestinal secretions. She is receiving analgesia and antiemetics via a syringe driver. This has provided reasonable symptom control but requires reloading by a nurse every 24 hours and will likely need further dose titration. She lives alone, but her daughter is nearby and supportive, visits daily and has been taught how to administer subcutaneous medications. The patient is deteriorating and desperately wishes to be at home as soon as possible, so is being discharged from hospital today. Not uncommon to get a referral like that this is happening, they're being discharged right now. She is aware her prognosis is likely to be a few weeks and would like to die at home. She hopes that as her needs increase, her daughter will be able to move in with her to provide terminal care. The patient is somewhat distressed regarding her deterioration but has clear goals for quality of life and spending time at home rather than pursuing life-prolonging interventions. So her physical symptoms, it sounds like she's had terrible symptoms that are now under better control with the subcutaneous infusion, but they've already said it's going to need further titration. So I think at least moderate for physical suffering. For psychological, she sounds like she's really quite distressed about wanting to get home and potentially other issues, so moderate there too. We don't really know how her daughter is travelling. We know she exists and has received some education, but we don't know how she's coping, so unknown for that. No urgent communication or information needs as far as we know. It sounds as though the right conversations have occurred, but we could gather some more information there. And she's being discharged today without the right equipment and services at home, so that's a current discrepancy between care needs and care arrangements. And there's definitely a mismatch between her current side of care and desired side of care. She's desperate to get home, doesn't want to remain in hospital. It's been quite clearly stated that her prognosis is weeks, so she's not imminently dying. So she scores 39, which puts her, for the community setting, in the crisis category. But your community service might even count her case as an emergency, given the subcutaneous infusion, given that she's going home today. It sounds that that's not negotiable from the hospital. And so she might be someone that you make an exception for and sort of drop everything to get to, but scores quite highly on the tool. So let's just run through some frequently asked questions that might have been generated by some of those cases and some others we might be able to think of. So firstly, syringe drivers in the community setting or subcutaneous infusions. So patients who are being discharged from inpatient care to the community setting whilst on a continuous subcutaneous infusion often require an immediate response from the community palliative care service to enable the infusion to be continued. But this does depend on local arrangements. So in some locations, this kind of task is done by a non-palliative community nursing service or a hospital at home service. So from our qualitative focus groups, this was discussed and therefore it hasn't been given a separate item on the triage tool whether or not they need a subcutaneous infusion, because it's not always a determinant of that urgency. So please complete the tool as usual, but override the score if necessary, if in your service that's something that automates your service needing to prioritise that patient. So item 5 regarding the discrepancy in care will usually be impending leading up to the discharge, or current if the discharge is really imminent. But as I said, it depends on how you locally operationalise this, and it might be a case where you need to override the tool score given the setup of services in your area. And number 2 there, respite referrals to the inpatient setting. So for respite requests, we complete the tool according to the patient's current situation. So item 5 regarding the discrepancy in care needs and care arrangements would be impending leading up to the required period of respite. For example, if the caregiver was planning a holiday, or it might be current if the caregiver has been incapacitated, they've broken their leg or whatever and are unable to care. And other issues may also be relevant, such as psychosocial distress of the patient or the caregiver, but not always. But sometimes when people really need respite, they're very distressed, so that would also flag and they would score points that way as well. It may be necessary to repeat the triage assessment, as you saw in the worked example, as the date of required respite draws near, as the score may increase if your services have not yet become available and the patient might be prioritised differently. Also, literature suggests that respite isn't always just respite. So please do a vigorous problem screening and really watch for unravelling if the patient is having to be placed on a waiting list and not able to access respite when it's requested. Number 3, suspected abuse. So situations of physical and or psychological abuse are very serious and they do warrant urgent attention. Depending on the severity and the immediate risks, it may be appropriate to use the emergency caveat and escalate the case for urgent attention regardless of the triage score. In other situations, these problems may just be flagged on one or more triage domains. So whilst this issue wasn't addressed specifically in our qualitative work, triage items that would be relevant would include the discrepancy between care needs and care arrangements, psychological suffering of the patient, and in some cases mismatch between the site of care and desired site of care, or distress of the caregiver, or physical suffering or distress of the patient. So really use your discretion. The items, it can flag on multiple items depending on how it's affecting the patient and caregiver, and may need to be escalated as an emergency regardless of the score. And finally, paediatric cases. So the Run PC Triage Tool wasn't designed for paediatric cases. The research wasn't conducted with paediatric palliative care clinicians, although people who do provide that care did participate, who provide care to both adults and children, So this cohort of patients may well have differing needs and issues compared to adult patients. So in future, we might actually look at this in a research capacity and release a paediatric version if required, or we might confirm that the tool is applicable in paediatric settings. But in the meantime, we would just encourage you to still use the tool if you do treat and manage paediatric patients, but anticipate that you might need to deviate from the tool, that there might be things that are flagging your clinical concern that aren't captured by the tool. And please do use the free text box to capture any other factors that you feel are relevant, and by all means prioritise them as you see fit. I just wanted to highlight that a lot of the information in this training is available in the user manual, which is also on our website. And on our website, you can also sign up to our mailing list where you'll be notified about any further resources, publications, new things, new projects. So please get online there and sign up to our mailing list. So thank you so much for your time today. I hope that the information and examples have been helpful to you and your team. And I just want to, while I'm here, thank my co-investigators who've developed the tool with me, and the funders, the State Government of Victoria, St Vincent's Hospital Melbourne, and the Bethlehem Griffiths Research Foundation, who've generously supported this work.